I'm so excited to introduce today's presentation to you and to the presenter. This presentation will describe the background and purpose of the Strong Start program and AABC enrollment goals, project and evaluation design, a look at preliminary data, and how this research might impact future access to midwifery and birth center care. Jill Alliman is our speaker today, and she's my friend, and I wish I could just stop there, but since I can't, I'm going to read to you her impressive bio. As a birth center midwife in rural Appalachia for 28 years, she's worked to improve access to care for some of the most underserved women in the United States. She serves currently as course faculty at Frontier Nursing University in the Nurse-Midwifery education program. She is also the program director of the AABC Strong Start Project, a grant program to measure the impact of birth center care on the reduction of preterm birth rates, collecting data in 45 birth centers with funding from CMS. Ms. Alliman believes, she's actually Dr. Alliman, I'm excited to say. Dr. Alliman believes that giving birth in the birth center can be a transformative experience for women, including the neediest women out there, empowering them to improve their families' situations for the better. Having helped a rural birth center to survive for over 26 years, she now uses that experience to make contributions to extending the birth center model of care for lots of women across the United States. In February of 2013, she became the project director of AABC Strong Start for Mothers and Babies. Over 4 years, this project will measure the impact of enhanced birth center care on preterm birth rates. Her work with AABC has demonstrated that even a small group of innovative, dedicated individuals can make a significant impact on the health care for women and newborns. So without further ado, I'm going to present to you Dr. Jill Alliman.
Hello, I want to thank you all very much for letting me talk a little bit today about the AABC Strong Start project. This is a very exciting project with some interesting implications for future access to birth center care and midwifery care for more women who currently don't have access to that care. Today I'm going to just go over a little bit of background about the scope of the problem of preterm birth in the U.S. And then we'll talk about the development of the Strong Start project for mothers and newborns. And I specifically am the project director for the AABC Strong Start project. So we'll go over the evaluation design for the program, and I'll present a little bit of preliminary data that we're seeing so far. We are currently have just finished years 1 and 2 of data collection, and we're starting year 3. Year 4 will be with the purpose of finalizing the evaluation. So I would also like to just touch briefly on some of the implications for future research in related areas. As I'm sure you're well aware, the cost of preterm birth in the U.S. is very significant, with estimates that it is greater than $26 billion per year. The long-term health impacts to infants who are born preterm are difficult to measure. The U.S. rate of preterm birth has gradually increased over the last couple of years, but currently at 11.4% is still higher than in most developed countries. In addition, in the U.S., we have significant racial disparities for African American women for all maternal outcome and infant outcomes, including preterm birth. So in 2010, as a part of the Affordable Care Act, the Centers for Medicare and Medicaid Innovations was founded to identify and develop new models of health care that could solve some of the problems, including looking at ways to reduce rates of preterm birth. The Centers for Medicare and Medicaid Innovation developed the Strong Start initiative for mothers and infants in 2 parts. The first part was to change the culture of elective delivery before 39 weeks in this country. And they did this by organizing large health systems, state perinatal health associations, and many others in order to actively go into hospitals and change current policies and procedures so that no elective deliveries could be performed before 39 completed weeks. This is one of the reasons that many believe that the rate of preterm birth has decreased slightly over the last couple of years in this country. Part 2 of the Strong Start Initiative is to find and test models of prenatal care that could decrease the risk of preterm birth for women who are more at risk for preterm birth. The evaluation of the Strong Start Initiative will eventually include linking cost data to outcomes of care so that we will have more information about the cost of care with these new models and how they can impact the outcomes. CMMI identified 3 models of prenatal care to study in the Strong Start Initiative. The first is called the Pregnancy Health Home, the second is Centering or Group Care, and the third model, where I am working directly, is the Birth Center Midwifery model of care. The American Association of Birth Centers convened a group of birth centers to apply for funding under Strong Start, because we were concerned that if the association was not able to apply for the grant, it was very likely that birth centers, being small healthcare facilities with smaller capacities, might not be able to apply. So in the end, we were able to identify and have agreement from 45 birth centers in 22 states to participate in our AABC Strong Start project. In order to be eligible, birth centers had to already be Medicaid providers because Strong Start focuses solely on women who are Medicaid beneficiaries or participate in the CHIP insurance program. For AABC, this has been a new experience in collaboration with the member birth centers and with the federal agency. So it's been an interesting experience for all of us in collaboration and how to expand access to the birth center model of care. Birth centers already have an impressive record of clinical and high client experience outcomes, such as lower cesarean rates, lower rates of other medical interventions, similar neonatal outcomes to hospital care, excellent maternal outcomes, cost savings that result from lower rates of medical interventions, such as the lower rates of cesarean sections with all the morbidities that can result, and in high rates of maternal satisfaction with the model of care. So the AABC project design is made up of focusing on the midwifery model of care, specifically midwifery model of care provided in the birth center setting, and with the addition of a component called peer counselor support. This was done because the funding was coming from CMMI, which is a branch of CMS, and it was a requirement that we had to add a component of care that was not currently being reimbursed by Medicaid. The project will consist of 3 years of enrollment and providing services, collecting data during that period. AABC's initial goal was to enroll 10,000 women with Medicaid or CHIP coverage and to spend the 4th year completing the evaluation of the project. The data collection process and services provided consist of first, screening women for risk factors for preterm birth. And this is done using the perinatal data registry, and all risk factors for preterm birth, which have been mutually agreed upon with CMS, are screened for and recorded. Women are then enrolled in the program after completing the informed consent process. Services are provided in the birth center, consisting of midwifery, birth center prenatal care, which is comprehensive prenatal care, in a model where the visits usually last longer than in traditional prenatal care. Women are able to ask questions, spend more time getting to know their midwife healthcare providers, and to develop relationships with their care providers. In addition, during those visits, women have at least 4 visits during the pregnancy with their peer support counselor, whom they meet with, discuss issues, go over needed resources, and gain another relationship with their peer support counselor. There are 3 ways that data is collected during the process of AABC Strong Start. The first is the client entered data in evaluation forms that were developed by CMMI. These forms are administered at intake, during the 3rd trimester of pregnancy, and at the postpartum visit. And they consist of very detailed screening questions about various risk factors for preterm birth. In addition, the AABC project includes provider-entered data where the midwifery providers in the birth center enter detailed demographics information and other variables and enter clinical outcome data. The clients also enter data in a new device called the AABC Maternity Surveys that was developed specifically for Strong Start. Women receive surveys throughout the pregnancy that they complete online and submit to AABC that can be linked to their clinical outcomes as well. The evaluation design overall from CMMI contains a couple of other components. The lead evaluation team is Urban Institute. We were very happy that Urban Institute is the evaluation lead in this project because they have previous experience doing research in birth centers with the birth center in Washington, D.C. So the evaluators do write case studies about the various birth center sites. They perform detailed site visits, going out and visiting the birth centers, and conducting focus groups with participants, and recording their experiences and interviews in very detailed case visits, case studies that are written each year of the project. The process and outcome data is collected in the perinatal data registry, as I said, including risk factors, demographics, the number of visits that women receive, number of interventions that they have, and any complications that occur. The outcomes that are recorded include mode of birth and very detailed neonatal and maternal outcomes. In addition, there is the client entered data of their evaluation and screening forms and the AABC maternity surveys. So although we are only 2 years into data collection, AABC does have some preliminary data. I want to stress the point that this is very preliminary data, and so we can't draw any conclusions from it at this time. But I wanted to just give you a little insight into what we're seeing in our preliminary data. First of all, we have detailed data in the AABC Perinatal Data Registry on over 6,100 women who are enrolled so far in Strong Start. And so far we have had 3,100 babies born that have had Strong Start interventions. Just some cumulative data that I can report as of our last quarterly report, which was the end of June of this year. The overall cesarean rate for all women entering care in the program is around 12.3%. The number of preterm births so far is 3.4%, which means that the term births are over 96%. Babies who are low birth weight has also been very low so far at 2.8%. And we have women completing postpartum care at just over 1,000 women. So we are interested in seeing these preliminary data, but again, can't draw any long-term conclusions from that. We also have some preliminary data from the evaluation forms that the women complete at their visits. And I wanted to show just a few of these because it's often the case that when readers look at studies of birth center care, they're quick to point out that birth centers are caring for low-risk women. And in this study, the Strong Start group is definitely a more diverse population than we usually see in the birth centers. So I'm going to make that point just by showing a few of the variables that are on the evaluation forms and comparing them with women from the other models that are being looked at. For example, we asked women about food insecurity, and the birth center population answered that they do have and are experiencing food insecurity currently at about the same rate as the other groups that are being looked at in Strong Start. Look at smoking, tobacco use. Strong Start women who are attending birth center care are just about in the middle of those rates. Depressive symptoms, also about in the middle. And if in the question, have you experienced intimate partner violence in a relationship, the birth center cohort actually has experienced this at a higher rate than the other models that are being looked at. So I think it's interesting to notice that the birth center population in Strong Start is a much more diverse population and is experiencing stressors that can lead to high risk of preterm birth at similar rates to the other models being studied in the project. These are some preliminary data about breastfeeding initiation, and on these outcomes, these are client-entered data, but you can see that breastfeeding rates are higher in the birth center group than in the other models. This is something that has been noted before in birth center studies. And if you look at satisfaction with prenatal care, again, women in the birth center group do express higher rates of satisfaction, being either very satisfied or extremely satisfied at much higher rates than the other groups. And in satisfaction with their birth experience, they are also very satisfied or extremely satisfied at higher rates than the other women. I wanted to give you an example or a couple of examples of what women say during the focus groups where the case study evaluators go out to the birth centers and meet with the participants and talk about the Strong Start care. For example, this woman says, after I lost the baby, I had just met my peer counselor at that point, but she stayed on with me and kept talking to me and kept me focused and grounded. So women are saying that having the extra support of a peer counselor at their visits has made a difference for them in feeling cared for and in being able to deal with their stresses. Other women in the focus group commented on the midwifery model of care and said they chose midwives because they feel listened to in this model of care. These are some initial responses on the maternity surveys where women are reporting detailed responses to their experience of care in the birth center model of care. In these responses, the questions include a range of questions about their knowledge levels and about their experience with the prenatal care that they are provided at the birth center. And the first question, how would you rate your level of knowledge about pregnancy? In this response, women did answer to a high level that they felt good or very good about their level of knowledge. And in this question, how worried are you about your ability to handle the pain during labor and birth? A significant number of women are either slightly or somewhat concerned about how they're going to deal with pain. So it's important to note that these types of maternity surveys are not yet available in the U.S. and women are not asked these types of questions to this point. So this maternity survey that's been developed by AABC for Strong Start specifically, we're hoping will be used after Strong Start and can be used more widely with other women in assessing their experiences and getting their not only their satisfaction, but their input about their experiences of care. Another question that's been very important to us in working with the Strong Start population is to try to develop materials that they can access from handheld or mobile devices. So one of the questions in the survey that we will continue to track is, how are you getting this information? How do you access internet? And how do you access online or digital educational materials during pregnancy? So you can see that about half of the women surveyed are using a personal mobile device as opposed to a personal computer. So in Strong Start, the AABC project, we have developed a website that's also very mobile, handheld friendly for other educational materials at low reading level for the women to use. So, as I said, we've just finished the second year of enrollment, and we're starting year 3 of enrolling women and collecting their data. As I said, enrollment now stands at just a little over 6,100 women enrolled. And we will continue enrolling new participants until around September of 2016. With the current goal of reaching at least 9,500 women and providing complete services to them through their postpartum period. After we complete providing services to all the women enrolled, then we will switch to evaluation mode in year 4 and be focusing on working on our own evaluation of these data and also working with the National Evaluation Project to make sure that they can complete collection of all the information that they need. In addition, in year 3, starting this year, we're going to be starting some pilot projects using the preliminary Strong Start data. We want to look at ways that these outcome data from women who are Medicaid beneficiaries with positive outcomes in the birth center model of care, how these data can be used to work to bring more better access to birth center care for more women in these income levels. So we're going to be piloting some pay-for-performance projects in the coming year. We'll be working with a few of our states where our birth centers are located with their Medicaid agencies and with their Medicaid managed care organizations to share these data with them, to show how good the outcomes are even with Medicaid populations and even with more diverse populations of women, and demonstrate the value and potential savings using the AABC model for the Strong Start population. Eventually, during year 4, these outcome data will be linked with claims and cost data from the individual states' Medicaid departments. That will provide us even a better understanding of the cost of birth center care. We have several other future projects that we would like to do. AABC has learned through this experience that it is important for AABC to administer and organize research so that individual birth centers can participate and conduct research at their individual birth centers that is then contributed to aggregate data to get a larger data set that can be used across the country. So future topics, we would like to do more research on the client experience of maternity care in various midwifery models and settings. We would like to understand with more clarity why birth center outcomes are traditionally so good. Why do birth centers experience such a low cesarean rate when low-risk women can go to hospitals and have much higher cesarean rates of birth? And we want to do more looking at linking the client experience data that we gather from maternity surveys with clinical outcomes to see what types of responses to client experiences, such as anxiety or concern about their labor experience, may affect then their clinical outcomes. We're also going to be working on developing some return on investment models so that we can demonstrate to payers the value in more depth, the value of birth center and midwifery model care. So this has been the beginning of an exciting new collaboration for the American Association of Birth Centers, for all of the birth center sites that have been willing to participate in this research, and we hope that it will be only the beginning of many more research projects to come. Thank you.